Welcome to another psychiatry lecture. I'm Sam Asgharian, and we're going to talk about anxiety disorders now. Specifically, we'll walk through panic disorder and the differences between that and phobias. So, for panic disorder, it's important to note that it's the experience of intense anxiety along with feelings of dread and doom, and that's a key indicator. If you see that the person feels like the world is about to end, and that's why you got that beautiful mushroom cloud image, that's an indicator of panic disorder. Specific phobias are triggered by particular objects or particular events like spiders or speaking in public, whereas panic disorder is generalized intense anxiety, basically that the whole world is ending. So for panic disorder, you're looking for at least 4 symptoms of autonomic hyperactivity. This will include sweating, trembling, chest pain, fear of dying, chills, palpitations, shortness of breath, nausea, dizziness, dissociative symptoms, and paresthesias. This is super similar to MI or cardiac events, right? So you always want to keep that on your differential. Is this person suffering from a panic disorder, or is this person having some type of acute coronary process? And if you think about the sense of dread, that end of the world feeling, their age and their comorbidities, that'll help you differentiate it from a coronary issue. So for timing and duration, you want to note that these symptoms last less than 30 minutes and they can be accompanied by agoraphobia. A lot of times this will come on suddenly. The person in the vignette will be on their way to work and all of a sudden they'll have all these symptoms and they'll feel that sense of dread, so much so that they'll have to duck away into a store or even a storage closet to get away from people to calm down until those feelings go away. In addition, in women, it can occur at any time and usually has no specific stressor. You want to rule out thyroid disease, hypoglycemia, and cardiac issues, just like we said. So a lot of times they'll tell you in the vignette that this is an otherwise healthy, relatively young individual and that these symptoms come on quickly and go away quickly. So you're definitely not going to just reassure these patients and send them on their way. You're also not going to just prescribe some type of clinical therapy. You're going to give them a pharmacological treatment. You usually start off with a selective serotonin reuptake inhibitor. Specifically, fluoxetine, paroxetine, and sertraline are indicated for panic disorder in addition to their use for mood disorders. Along with the selective serotonin reuptake inhibitor, you can add a benzodiazepine. Alprazolam is one used commonly for panic disorder. However, you do taper that benzodiazepine. It has a higher potential for abuse and it's not as well tolerated as the SSRI. So you get them to have basically a resolution of symptoms. You put them on monotherapy eventually on the SSRI, but you do want to have behavioral individual therapy there for support. However, you cannot prescribe that as the only treatment. You want to include the SSRI and the benzodiazepine at first. So here's a good question. Which is the first line treatment for panic disorder? What are you going to give them first? Well, the question's important. It says panic disorder. If it said generalized anxiety, then you could say B. If it said panic attack, if they're actually undergoing an acute event, you definitely could say A. But because it's panic disorder, the first line treatment is the SSRI, choice C. We ruled out alprazolam, we ruled out buspirone, we rule out imipramine because that's used for major depression and enuresis, and fluvoxamine isn't a first line therapy. So the SSRI, choice C, is the correct answer. Moving on from panic disorder, we'll discuss phobias. That's the fear of an object or situation and the need to avoid it. It can be learned, it might not be innate, and it involves 2 main types: a specific phobia, such as this, and this is bad for me because I actually am deathly afraid of spiders. It's the fear of an object, animals, heights, cars, something like that, and that hairy, disgusting thing on the screen is something that I have a specific phobia against. We'll discuss phobias a little bit more on the following slides as I get through this as quickly as possible. In addition to that specific phobia, a lot of times you'll hear about social phobias. This is the fear of a situation. This reminds me of my favorite, basically, anecdote ever. It's said that of a survey of people, the number 1 fear of the common person is public speaking, while the number 2 fear is death. So the joke is that the person giving the eulogy at a funeral is actually having a much worse time than the person in the coffin. So, in addition to that, public speaking and death and whatnot, you could have a fear of public restrooms. People have to go home to use the restroom because they don't like going to the bathroom in public. Eating in public absolutely could be a social phobia. And there's that one I just discussed, the public speaking. Situations where something potentially embarrassing may happen would provoke a social phobia. So, how are you going to diagnose this? Well, you're going to look in the vignette for a history of anxiety symptoms in specific situations. It'll say when they go up to speak at a meeting, or when they go to use a public restroom but they can't, or when in contact with feared objects. Just how a couple slides ago I saw one of the most disgusting pictures of a spider and I could feel my blood pressure and heart rate go up, that would help with the diagnosis of specific phobia. The treatment for this is behavioral modification techniques, and an important one that's used is systematically desensitizing the person to that feared issue. So you'd expose them to the feared objects, moving from least fearful to most anxiety provoking. So, if, using me again as an example, you would give me maybe tiny baby spiders or put them in a little box in front of me and show me that they're harmless. And then further on, you would ultimately get me to the point where I could hold, say, a tarantula in my hands. That's systematically going to desensitize me to my phobia. You can use the same techniques for a social phobia, getting them to speak in front of small members of their family, ultimately into larger groups until they overcome that fear of public speaking. So notice so far that I haven't mentioned any pharmacological treatments. So first you try to desensitize. In addition, you teach them relaxation techniques, deep breaths, guided imagery, so think of a happy place. Beta blockers, the atenolol or propranolol, whenever you go to the pharmacy, are only used for performance anxiety, such as stage fright. They're given 30 minutes to 1 hour before performance. So don't choose an answer choice that's a medication. Reserve that answer choice only for someone who's a performer, who has to go in front of an audience. Then you can prescribe the beta blocker. Let's do a good case. A 40-year-old man referred to a psychiatrist because he is too shy. He has problems going to parties, feels anxious about getting close to others, and stays at home in fear that others would laugh at him. When confronted by others, he develops severe anxiety as well as hyperventilation and increased sweating. So we have those autonomic symptoms. Let's see what our ask is. What is the most likely diagnosis? So panic disorder is there because he's got these autonomic symptoms, but are they to an actual stressor? It seems so, right? When he's involved in a group setting, he has these issues and it's affecting his social functioning. He wants to go out. He does go out, but eventually he stays at home because he feels too shy. So we'd pick B, social anxiety, as our correct answer. He doesn't have that feeling of the world is ending, that dread and doom. He also doesn't have generalized anxiety, so he's not worried about everything. He's just worried about these public settings. It's not a specific object. These aren't spiders or heights that he has an issue to. And remember, an acute stress disorder, from your reading, it's a stressor 2 days to 1 month after an event, like a traumatic event. There is no car accident here or anything like that we know that led to these symptoms. So B, social anxiety, is our correct answer. Now that we're done with the anxiety disorders, we're going to talk about one that's relatively prevalent in medical school, obsessive compulsive disorder. So we're not talking about a personality disorder, which might fit the bill of a lot of classmates you have in medical school. We're talking about the true obsessive compulsive disorder, OCD. So obsessions alone, or most commonly a combination of obsessions and compulsions. Typically, this affects the individual's level of functioning. Can they work? Can they leave the house? Can they have a stable relationship? If not, then you want to move obsessive compulsive disorder up the differential. What we mean by obsessions and compulsions is they're obsessed with this thought that they're dirty, and therefore they compulsively have to wash their hands. It could be anything. They're obsessed with the thought that their house isn't secure, so they compulsively have to check that all the lights are off and all the doors are locked. So a little bit more detail, those obsessions are thoughts that are intrusive, senseless, and distressing, thus increasing anxiety. It's a fear of contamination. They're dirty. Compulsions are the rituals, such as counting and checking to neutralize those thoughts. So basically, they do this to ease themselves. It's the only thing that can relax them in this disorder. Otherwise, those thoughts, those intrusive thoughts, run rampant and prevent them from functioning. The compulsions are time consuming though, but they do tend to lower the anxiety. So they'll lock, relock, check, check again, they'll go back, unlock, lock again, check the door, and they will have to do this over and over. So much so that they actually spend hours doing something that takes people seconds to do. So, for the diagnosis, you'd see obsessive compulsive disorder more frequently in young patients. The incidence is equal between men and women, and it can coexist with Tourette disorder. Remember, we discussed that earlier in the psychiatry lectures when we said it's motor tics or vocal tics. You can see a combination of someone having obsessive compulsive disorder and Tourette disorder. What are you going to do to treat it? You're going to give them SSRIs. Hopefully you've noticed this pattern. SSRIs are a psychiatrist's best friend. You keep those in your toolkit and you can pull them out for multiple different issues. Here, a selective serotonin reuptake inhibitor can quell the symptoms of obsessive compulsive disorder. The first-line treatments are fluoxetine, paroxetine, sertraline, citalopram, or fluvoxamine. Main behavioral therapy used is exposure and response prevention. You would actually put this person in front of an unlocked door and tell them that it's okay if they don't lock that door. Or you put them in front of a sink and tell them that everything will be all right if they don't wash their hands. And that helps them relax and eventually breaks down that obsessive compulsive disorder that affects their functioning. Another topic that pops up on step 2 is PTSD and acute stress disorder. We'll discuss those two and their differences, as well as how they're different from other issues you might see on the answer choices. So let's take a look at what they mean. In both post-traumatic stress disorder and acute stress disorder, individuals have been exposed to a stressor. That's important. That's why it's bolded. And they have a reaction that leads them to feel more fear and helplessness than you would expect. The patients continually relive the event and avoid anything that reminds them of the event. It's usually an overwhelming event, especially for post-traumatic stress disorder. It could be a war, it could be a rape, hurricanes, or earthquakes, something extremely traumatic that they can't get out of their minds, and anytime they try to sleep or they lay down or they're quiet, they relive the event over and over again. Eventually, this affects the patient's level of functioning. Here's another one where you want to count the symptoms. Do they have an increased startle response? Are they hypervigilant? Do they tell you that they have sleep disturbances? Are they having outbursts of anger? And or are they having concentration difficulties? Basically, what you want to note is the person depressed? And basically, the number of symptoms in the timeline doesn't fit the diagnosis of depression. And you know from the vignette that there was an actual significant stressor, such as they were involved in a major car accident, a shooting where someone that they were close to died, or a war event. Then you can say, all right, it's not major depression, but it is post-traumatic stress disorder or acute stress disorder. Let's take a quick look at the main difference between PTSD and acute stress disorder. So for PTSD, the symptoms must last for greater than 1 month. For acute stress disorder, the symptoms last for greater than 2 days and a maximum of 1 month. They occur within 1 month of the traumatic event. So typically for the exam, what they like to do is basically set you up with a severe traumatic event, such as a shooting where someone witnesses someone, family member or a friend, a loved one, die next to them. And they might have been injured in that event. So what that means is they were admitted into the hospital for treatment. And during their admission, they fall under the symptoms of acute stress disorder. Whereas PTSD, there's the traumatic event, and they're not in the hospital per se. On an outpatient basis, they come to the clinic and they're complaining about the symptoms of post-traumatic stress disorder. So that's how you want to differentiate the two for the purposes of the exam. So the main feature here is you have to determine the time period when the traumatic events occurred in relationship to the symptoms. You want to rule out the depression, like we said, and you also want to rule out substance abuse. Both worsen the diagnosis, so they can be comorbid with depression, or they may be self-medicating with some substance to make them feel better, and that worsens the actual diagnosis. How are you going to treat this? First line, there's the SSRIs, paroxetine and sertraline. Relaxation techniques and hypnosis have proven to be helpful. And psychotherapy after traumatic events will allows for the development of coping techniques and acceptance of the event. If someone has been in a sexual assault or a major motor vehicle accident that they feel like they're the one to blame, you want to make sure you give them the medication, but you also prescribe the psychotherapy to help dampen the severity of their symptoms. Let's do another good case. We've got a 35-year-old woman with palpitations, dizziness, and increased sweating for 8 months. Has visited numerous physicians, none have been helpful. Her husband is concerned because she cannot relax and worries about everything. She worries about her parents' health, even though they are healthy. She worries about her finances, although her husband assures her they're financially secure. What's our ask? What is the most likely diagnosis? Let's take a look. This is someone who's worried about everything. It literally says that in the middle of the vignette. So you can throw out phobias and panic disorder. She doesn't have that feeling, that sense of doom. Basically, if she's worried about everything, she has a generalized anxiety disorder. Phobias have to be specific, remember, either that or social. She doesn't have those issues. Panic disorder, there's no dread and doom going on here. There's no specific stressor. Remember, her husband's telling you that he tells her there's nothing to worry about. And social anxiety is in specific situations, most likely in front of strangers. She's like this at home in front of her husband. So A, generalized anxiety disorder in a relatively young woman with no other comorbidities listed is the correct answer. That leads us to a quick talk on generalized anxiety disorder. We've already gone through a lot of it, but we'll go deeper and especially talk about treatments. So the definition is excessive anxiety and worry about most things lasting greater than 6 months. It's out of proportion to the event. So remember, it said clearly in that vignette that the person's parents were okay, but she would worry about their health nonetheless. It's accompanied by fatigue, concentration difficulties, sleep problems, muscle tension, restlessness, and it's usually women who complain of feeling anxious as long as they can remember. It pervades their life and lowers their quality of life. It'll manifest itself physically, taking a greater toll on that person as the duration of the disorder persists. Treatment here, remember I told you it's the psychiatrist's best friend when in terms of prescribing something. The selective serotonin reuptake inhibitors, fluoxetine, paroxetine, sertraline, or citalopram. Venlafaxine and buspirone have also been used, so note that. If you don't see an SSRI, those are the two you can pick on. And psychotherapy and behavioral therapy are helpful. In addition, though, they're not considered first line. You're going to give them the medication and have them follow up with you for psychotherapy and behavioral therapy. All right, we know that adverse effects of medications are definitely fair game on step 2. So let's discuss some for the anti-anxiety medications. We'll go through the list of benzodiazepines first. So that includes diazepam, lorazepam, clonazepam, alprazolam, oxazepam, chlordiazepoxide, temazepam, flurazepam. The adverse effects for these are sedation. Benzos will sedate you, confusion, memory deficits, respiratory depression, and addiction potential. Buspirone is better tolerated. It leads to headaches, nausea, and dizziness. So remember, the benzodiazepines, if taken in excess, can lead to either an accidental or a purposeful overdose. So you want to be careful with those. And buspirone tends to be much better tolerated. We'll continue with lorazepam. It's used frequently in emergency situations because it can be given intramuscularly. Clonazepam, it may be used if addiction is a concern because it has a longer half-life, so it's less addicting. Chlordiazepoxide, or oxazepam, used frequently in treatment of alcohol withdrawal. So if someone is basically inpatient and you're worried about them undergoing alcohol withdrawal, you can prescribe one of those options. For alprazolam, note that it's used frequently in panic disorder. Flurazepam, temazepam, or triazolam are approved as hypnotics, rarely used. So really the key one on here is to note that alprazolam will be used in panic disorder. And we'll finish with this extremely important slide, so pay close attention to these details. Flumazenil is a benzodiazepine antagonist. It's used only when the overdose is acute, so you might actually even administer this in the ambulance on the way to the hospital if you know for certain that the person is overdosing on benzodiazepines. And you're certain that there's no chronic dependence. That's a big one. It won't work, especially in someone who's chronically used benzodiazepines. So flumazenil can cause seizures in benzodiazepine dependent patients. It causes acute withdrawal, tremor or seizures similar to delirium tremens, which you see in alcohol withdrawal. So this isn't an option you would go to very quickly. Make sure you note what the vignette says specifically about the person before you treat them with flumazenil.